Hello, everyone, and welcome to the Parkinson's Foundation's Wellness Wednesdays webinar. Thank you for joining us. We will begin soon. Please know we are recording today's presentation and you will receive a follow-up email from us with a link to today's recording and additional resources in about 1 week. Thanks for being here. Before we get into it, I want to remind you about our other PD Health at Home virtual programs. Each week, we offer sessions tailored to support people with Parkinson's and their care partners, including Mindfulness Mondays, Wellness Wednesdays, Fitness Fridays, expert briefings, and our Spanish language series, EP Salud en Casa. Be sure to visit our website to see what's coming up and explore our archive videos on YouTube. Learn more about upcoming virtual programs and register at parkinson.org/pdhealth. Additionally, based on who is here today, I'd like to share a few specific resources for those of you who are newly diagnosed and for those who are supporting someone living with Parkinson's. The Parkinson's Foundation offers guidance, emotional support, and resources to help you and your loved ones navigate the diagnosis. For some, a Parkinson's diagnosis comes as a relief, an explanation for previously unexplained symptoms. Others may be stunned, struggling with what the future may look like. And as you begin processing your emotions, which can be wide-ranging, it's important to know that you are not alone. Get connected to essential resources by visiting our newly diagnosed webpage. My colleague has shared that link in the chat. And for those of you who are supporting someone with Parkinson's, it's important to know that the foundation has a space for you too. Whether you're new to caregiving or have years of experience, this dedicated webpage meets you where you are with practical tools, educational content, and emotional support. You'll find printable guides, videos to navigate the evolving role of caregiving. It also connects you to programs like our Care Partner Summit or Care Partner Conversation series, our PD Health at Home mindfulness and education sessions, and relevant episodes from our podcast. For those planning ahead, we offer trusted tools like the Hospital Safety Kit, advanced care planning guidance, and legal considerations. Please bookmark or share this page with others. It's a comprehensive starting point and a trusted place to return to as needs change. Today, we kick off our newest series, Coffee and Conversations, with the Foundation's Chief Medical Advisor, Dr. Sneha Mantri. Today's session, we will focus on answering your questions, addressing the movement symptoms of Parkinson's. From tremors to stiffness to changes in balance, we will explore the symptoms that are most visible in Parkinson's. So grab your coffee, tea, or some other hydrating beverage like water, and prepare your questions about the movement symptoms of Parkinson's. Here's a snapshot of the conversations to come in the new year. These subjects were chosen based on your continuous feedback and the expression of your needs. So be sure to stay connected with our virtual education programs by visiting parkinson.org/pdhealth. And as we open our coffee and conversation today, focusing on the movement symptoms of Parkinson's, I'd like to introduce the Parkinson's Foundation's Chief Medical Officer and Associate Professor of Neurology at Duke University, Dr. Sneha Mantri. Joining Dr. Mantri is Dr. Matthew Burns, Movement Disorder Specialist and Researcher at the Norman Fixel Center for Neurological Diseases at the University of Florida. Dr. Mantri, I'll pass it over to you now to open our conversation on the movement symptoms of Parkinson's.
Wonderful. Thank you, Krista, for that delightful introduction and walking us through, what to expect from this new series. I'm very delighted today to be joined by Dr. Matthew Burns, one of my colleagues in movement disorders. We're both movement specialists, and we're here to sort of answer your questions for people with Parkinson's disease. One of the things that I really feel passionate about as a movement disorder specialist and as an educator myself is knowing how challenging it can be to get some of these topics addressed during a very busy clinical visit. And so the purpose of these coffee conversations is to give a forum for patients, care partners, loved ones, people who are curious about Parkinson's disease, to sort of ask the questions that you feel comfortable. And Dr. Burns and I will do our best to answer as many as we can over the next hour. As Krista mentioned, our focus for this session is going to be on movement and physical symptoms in Parkinson's, but we have a whole lineup plan for 2026 addressing various different topics. So if you have a question that we don't get to today, please know that we'll keep it on our radar. And if it fits naturally with one of our other sessions, we'll certainly bring it up then.
Dr. Mantri, thanks for the introduction, and I appreciate the opportunity to participate.
So let's start with the first question. What are some of the best treatment options for movement symptoms?
Great question. I would say that, I think about treatment for movement symptoms in a few different ways. One is I think it's always important to remember that there are non-medication things that you can do to help with movement symptoms in Parkinson's disease. Probably the best example of that is exercise. Both aerobic exercise as well as stretching and strength training can be really powerful ways of helping to address movement symptoms in real time, as well as help slow down the course of the disease over years and decades. There's also a lot of different medication strategies to help manage movement symptoms in Parkinson's. The most common ones that we sort of often turn to first are the dopamine-based therapies, things like carbidopa, levodopa, which sort of refills your dopamine tank, if you will, and gets you that dopamine on board so that you can move more fluidly. There are related medicines called dopamine agonists that work by sort of tricking your brain into thinking that there's more dopamine around than there really is. And so can address a lot of the Parkinson's symptoms through that mechanism. And then for some people who might have, specific symptoms, for instance, a tremor that may not be fully responsive to dopamine, we also use other types of medications that kind of address that component more directly. Things like anticholinergic medicines, trihexyphenidyl tends to be my go-to in clinic. Dr. Burns, I don't know if you have any others to add to that.
Yep. I think those are a good list of medication to go to. And by and large, the first type of med we reach for are meds that modulate dopamine. Often when I'm seeing a new patient who has symptoms of Parkinson's disease, um, our the first thing we talk about is exercise. And that's because it's really the only evidence-based therapy that's been shown to slow progression of disease. Everything else we have is merely symptomatic management. And so I want to start with the most evidence-based treatment and the one that has potential to slow progression, and that's exercise. Um, and we can talk a little bit more about what exercise means based on the evidence. But after mentioning that to patients, what I'll then say is Parkinson's disease is a little bit different than, say, a bacterial infection. If you have a bacterial infection, um, I I will prescribe an antibiotic, and you have to take the antibiotic, or the disease won't go away. And if you take the antibiotic, the disease will go away. Um, in Parkinson's disease, just because you have the diagnosis doesn't mean you have to take any medications, um, because all of the medications, save for exercise, are symptomatic treatments. And so I have some patients who have significant tremor, significant other symptoms, but for them, it doesn't affect their quality of life. They don't find it impairing or embarrassing or painful. They don't like pills. And so it doesn't bother them. And so it doesn't bother me. And we don't treat. I have other patients with what I would say would be more subtle symptoms, but that matter a great deal to them and how they want to live their life. And for those patients, we treat aggressively. And so treatment is conceptualized more around symptom management than merely just treating the diagnosis.
Well, thank you both for really giving us a scope of what we can expect for best treatment options for Parkinson's. And I hear there's twofold exercise, which could Dr. Burns and Dr. Mantri, would you identify exercise as a disease modifying therapy as opposed to a symptomatic management therapy?
I think it's a little bit of both. As Dr. Burns mentioned, it really the only good evidence as a disease modifying therapy. We've certainly looked at a number of different medication options as disease modifying therapies over the last 50 years or more. And unfortunately, there aren't medications right now that are disease modifying, but exercise definitely is. So I would say that it's disease modifying, and for many patients, it also has an immediate symptomatic benefit. If you think about it, a runner's high, for instance, is essentially flooding your brain with lots of dopamine. So it's going to make that dopamine release that you can get from exercise can make your Parkinson's symptoms better in the moment, as well as long-term, stability in disease.
And so when I'm talking to a patient about exercise specifically, some patients will say, "Oh, yeah, yeah, yeah. Doctors are always talking about exercise. So what does that even mean? What am I supposed to do?" And so what I tend to say is, well, based on the evidence, you want to aim for at least 150 to 180 minutes a week. So that's 30 minutes a day. It doesn't matter how you distribute that therapy. So it can be 30 minutes a day, it can be 60 minutes every other day, however you want to do it. And what I tend to say is start with some mild to moderate cardiovascular exercise in any form that you enjoy. Walking, running, swimming, rock steady boxing, whatever. It doesn't really matter the form, but the goal is for that period of time, try and get to a level of exertion where you can continue a conversation, but you would be taking breaths in between sentences as you do it. No more vigorous than that. And that's roughly zone two-ish if you have a monitor or um, pay attention to that kind of stuff. And then round that out with twice a week weight training and some balance therapy or balance training. That would be a very evidence-based, very effective exercise regimen.
And I agree with that. And I'll just add that at the foundation, we just put out our 2026 updated exercise infographic one pager. So perhaps we can drop a link to that in the chat if people haven't seen it already. It sort of lays that out in this really nice visual for people, because it's important, I agree, to have both the aerobic component, the strength component, the flexibility component. Exercise means a lot of different things.
And just to clarify, what does it mean to be disease modifying?
I would say, the goal of a disease modifying therapy, whether it's medication or exercise or diet or what have you, is slower progression over time, meaning less worsening of symptoms over time. That does not necessarily mean an individual is fully stable in their symptoms. They likely will see some progression over years and decades, even with a disease modifying therapy. I think it would be a very tall order to ask a disease modifying therapy to reverse symptoms and sort of restore function. That is certainly one avenue, but I think um, uh, that is a very difficult thing to achieve. So just to be realistic about expectations, a disease modifying therapy means that you are progressing at a slower rate than somebody who is otherwise identical to you, but is not on the disease modifying therapy. So it's a little bit of a mind shift, I think, for many of us, in terms of thinking about treating treating the long-term progression of the disease and kind of trying to compare that to where would you be if you were not taking this disease modifying therapy, whether that's if you were not exercising or if you were not taking medication or what have you.
Thank you for clarifying that. There's a lot of buzz around disease modifying, and I think it's important to hear that exercise, we know, evidence-based, does modify the progression of Parkinson's. So thank you both for addressing the importance of exercise as we age, just as humans, but even more so as humans with Parkinson. So thank you for both for kicking this conversation off with the importance of exercise. So I'm curious to hear more about some of the really specific movement symptoms of Parkinson's, like dystonia and dyskinesia. Could either one of you either define what dystonia and dyskinesia is and perhaps talk about some of the best treatments or ways to manage dystonia and dyskinesia?
Dr. Burns, would you like to start and then I'll jump in?
Sure. So just as far as um, categorizing different types of movement symptoms, um, you know, we think about there is a long list of symptoms that are associated with Parkinson's disease, and an individual patient may have subsets of those, and so not everyone has every symptom that some other person has. Um, but with that caveat in mind, the core motor symptoms that we use to for diagnosing Parkinson's disease are a rest tremor, sometimes worse with distraction. In the clinic, we'll ask someone to recite the months of the year backwards or count backwards, just as a way of distracting someone and bringing out that tremor. And that's a particular characteristic that tends to be specific to Parkinson's. So a rest tremor, worse with distraction. Slowness, and that could be often in clinics, rapid alternate slowness with rapid alternating movements. And that slowness, um, usually that slowness shows decrement. So the amplitude of the movement gets smaller over time. A practical example of this that some patients may experience is if they're writing out a long sentence, the letters get smaller and smaller and smaller as they write. So that's an example of slowness with decrement. Rigidity is a particular type of stiffness that we can feel on exam and also gets worse with distraction. And then gait instability or balance problems. If a patient has two of those four symptoms, often with other Parkinson's-related stuff, that meets diagnostic criteria for Parkinson's disease. And those are the core motor symptoms. But there are a long list of non-motor symptoms, things like GI disturbances, sleep problems, mood, anxiety, hallucinations, the list goes on and on. Treatable, potentially treatable, but sort of non-motor is a second class. Dystonia and dyskinesia are types of motor symptoms that will happen to some people, but not so consistently or frequently as to be diagnostic criteria. Dystonia is an abnormal cramping or pulling of agonist and antagonist muscles around a given joint. So Parkinson's patients sometimes will experience this in a hand, where a hand becomes sort of postured and stiff. Sometimes they'll get toe curling, and then sometimes dystonia of the neck, called cervical dystonia. Um, but dystonia can manifest as a sort of vaguer pain type syndrome in the back or shoulder. And we have some patients referred to us by orthopedics after a surgery didn't do anything for that patient because the patient has Parkinson's related dystonia. So think of it as an abnormal cramping of muscles around a joint related to the underlying dopamine deficiency and potentially responsive to dopaminergic therapies. Dyskinesia is a sort of a abnormal fidgeting or wiggling movement. It can look dance-like or just like a patient is uncomfortable in the chair or fidgeting. They themselves may not notice it. Often a spouse or family member brings it up. And that is so. And if you see Michael J. Fox interviewed, that's a extreme example of dyskinesia. Um, that is not caused by the medication per se, but it's a movement related symptom that results from the combination of meds and disease progression. So why do I make that distinction? Because early in disease, even if you're taking a high dose of carbidopa levodopa, you may not get any dyskinesia at all because the disease has not progressed to a point where the meds start overflowing onto other dopamine receptors and causing the symptom. And the reason why I'm belaboring this point is that I have some patients who come in and say, "Oh, no, no, I've seen Michael J. Fox interviewed. I don't want that carbidopa levodopa. I don't want that dyskinesia." And the med, I'll become either dependent on the med or it's going to make me get dyskinesia. That's not the case. Um, the dyskinesia will happen over time because of disease progression. And if someone abstains from meds for 10 years and then starts carbidopa levodopa late in disease, they may get dyskinesia more quickly because, again, it's a combination of disease progression plus meds. Um,
Yeah.
so,
I think that's a really, really important point, and I just want to re-emphasize that for our audience because it's a subtle point, but it's a point that people get really sort of it can be hard to wrap your head around, right? Like I've also had those patients who come in and said, "Oh no, like I don't want dyskinesia like Michael J. Fox or my friend who's had Parkinson's for 15 years and is dyskinetic, and I'm afraid the medicine is going to do that to me." And it's important to remember it's not even so much about the medication, it's about how long you've had disease. There was a somewhat unfortunate natural history experiment, if you will, that was published a few years ago, looking at people with Parkinson's disease in Italy, where access to levodopa is, relatively available in pharmacies and at doctors' offices, and diagnosis is relatively available to people. So comparing people in Italy with people in sub-Saharan Africa, I think specifically Ethiopia and Eritrea, where there's a lot more access challenges, both in terms of getting a diagnosis of Parkinson's, but also then getting, adequate amount of medication. What they found was when you're comparing rates and the development of things like dyskinesia, it wasn't so much about how much levodopa you're taking. That is a little piece of it. But the bigger factor was how long you had Parkinson's disease. So that's important, I think, to keep in mind.
yeah. And I sometimes I'll have patients say, "Well, I'm gonna hold off on the meds, or I'm gonna hold off on that dose increase because I want the meds in my back pocket when I really need it." And I understand that impulse, that sensibility, but the meds you forego today only represent the benefit you could have had today.
You
And
don't want to miss the honeymoon period, is
you're
how I
not
say
saving
that.
anything up for later. That's just the nature of symptomatic treatment and the underlying disease progression.
So there's a few questions that's elaborating what our community wanting to elaborate on freezing and if that is considered a movement or motor symptom of Parkinson's. And then also, Sandy would love to hear the difference between bradykinesia and dyskinesia.
Yeah, both great questions. So I'll take the one about freezing. It is considered largely a motor symptom. Freezing of gait is essentially where you might stand up from a chair or go to turn around, or sometimes, try to walk through a cramped or crowded or narrow space like a door frame. And all of a sudden your feet feel like they stop moving. They feel like they're frozen to the ground. And people will sort of try to move. Often you'll see patients sometimes try to rock back and forth to get their feet moving again. And sometimes people are able to break the freeze that way and continue moving. Sometimes they need some other strategies. Sometimes like counting backwards or counting forwards, saying 1, 2, 3, go. Something like that can help break the freeze. If you've got an ability to look at, say, like the line of a floor tile, or with a laser light like they have on certain types of walkers, that can sort of draw a line for you on the floor, that can be a visual cue that can help break the freeze. And our physical therapy friends have all kinds of other tricks that I know they teach patients on how to break a freeze if it happens, because it can be a really challenging thing. It can be, number one, scary when it happens, when your feet aren't moving like they're supposed to. That in itself can be scary. And the other thing I worry about with freezing sometimes with patients is if your center of gravity gets off kilter, right? Because your upper body is moving forward, but your feet are stuck. that is a very, very common reason why people might fall. So freezing is definitely something that should be addressed, can be addressed with physical therapy, with other types of devices. Sometimes medication adjustments can also help with freezing. But I usually refer people first to PT and kind of thinking about devices and non-medication ways to help with freezing, because those are often the most effective for most people.
And Dr. Mantri, why does freezing happen in Parkinson's? What's the phenomenon behind this?
I'm
Oh,
glad you
that
got
is
this
like a
question and not me.
$1 million question. Yeah, I know. I see Dr. Burns being like, I'm gonna step back. I wish we knew. I mean, it's a complex motor phenomenon. It probably has to do with multiple brain regions, not just the sort of substantia nigra striatal pathway that we think about a lot in Parkinson's disease. But freezing probably also has to do with the frontal part of your brain. So like right behind your forehead, there's sort of higher level motor control there. There's kind of walking centers or motor centers in the middle part of your skull, of your brain. There's areas in the very base of your skull that are controlling walking and movement. So it probably has to do with the integration of all of those different networks and pathways. Which is why it's such a challenging thing sometimes to treat, because it's probably not just one issue. It's probably something with the balance with all of these different brain networks that gets sort of off kilter when you're confronted with a new situation or new stressor. So going through a doorway, or sometimes even like being at the top of a flight of stairs and kind of looking down at the flight of stairs, like that can be enough to trigger freezing in some people. So you have to be very careful and very mindful of where you are and what your environment is like.
And Dr. Mantri brings up an important point about freezing specifically. It walking in general and freezing in particular represents kind of an interaction between some of the automated functions of movement and more conscious volitional parts of movement. And so as a result, sometimes conscious effort or mental tricks can break a freezing episode. And this is where caregivers can play an important role. So often physical therapists have nice tricks about looking at a line on the floor or stepping over that line or a laser or thinking about marching in place to break a freeze or a turn. I think sometimes well-intentioned caregivers in a freezing episode can just say like, "Come on, go already. Come on, make," and we'll try and be a cheerleader and we'll just stress people out. As well-intentioned as that is, if a caregiver can participate in the physical therapy session, learn of like a verbal cue or guide that reminds a patient to use some of these tricks to break a freeze, that can be incredibly helpful. And I think matters for caregivers who want to help, who want to contribute, but often kind of don't know what's going on inside the mind of the patient. Um, and then with regard to the difference between bradykinesia and dyskinesia, it's a terminology thing. Bradykinesia is just Greek for slow or delayed, and so it just means slow or delayed movement. And so it's a word that is meant to represent a particular characteristic of a lot of types of movement in Parkinson's patients, whether it's rapid alternating movements with finger taps or opening, closing a hand, or slowness of walking. Dyskinesia just means ill or problematic, diseased movement, also from the Greek, and that word is meant to represent this sort of fidgety, sort of flowing, maybe almost dance-like movement that is a result of the interaction between disease progression and some dopaminergic meds.
Thanks for differentiating that, Dr. Burns, and recognizing. So, what I heard with the freezing, there's a couple of things. We got a question about what devices help with freezing, and I heard a walker with a laser light. And when we think about devices, there was a lot of conversation about tools and tips, mental tricks that you called them, Dr. Burns. So, want to just articulate that a little bit louder for those who are looking for ways to manage their freezing with mindfulness, with mental tricks, perhaps with a walker with a laser light. Am I missing anything here, Dr. Mantri or Dr. Burns?
I think those are the biggest ones. The other one that Dr. Burns had mentioned that I've also seen quite useful for people is marching in place, can be really helpful. I did my fellowship through the VA system. And so a lot of the veterans would say, oh, when I get a freeze coming on, I'll sort of go back into, marching mode, right? That they learned when they were in the army, say, and that will help break the freeze. Music can also be helpful sometimes, again, having that rhythm or that beat. And there are even, devices like pocket metronomes, pocket like vibrating tools. Some forms of smartwatch you can set like a vibrating rhythm on that, and having that cue can help to break a freeze if it happens.
And it takes some trial and error.
Yeah.
So for some people, the particular cue is specific to them, sort of idiosyncratic, and that's sort of figuring it out, working it out with both a caregiver and a physical therapist, I think is important.
Mhm.
So we have a couple of people writing in, Gwendolyn saying marching helps her husband, and they also count. And Mark wrote in some cues. This is a great example. Mark, stop, stand up straight, settle your feet, and take a big step. So this is an example of the mental tricks that we can do to get the feet to move. Final question on freezing. Does everyone who is impacted living with diagnosed with Parkinson's, can they expect to develop this movement symptom of freezing gait?
I don't think everyone. I think it's very rare that everyone with Parkinson's experiences any one thing, given the complexity of the symptoms. I think it is something that affects most people at some stage in the disease, usually after many, many years of living with Parkinson's. If somebody were having significant freezing in the first few years after diagnosis, that would be a little bit of a red flag for me to look for some other cause or some other reason as to why that's happening.
Yeah. And therapies like dopaminergic therapies, carbidopa, levodopa, are just more variable in their efficacy. So I have some patients who swear up and down, they take their carbidopa, levodopa, their freezing goes away. I have other patients who say they take their carbidopa, levodopa, and the freezing gets worse. Um, Deep brain stimulation, other surgical therapies, or non-dopaminergic therapies has there have been some question of benefit here and there, but nothing consistent and nothing significant as far as treatment.
In the same vein of freezing, we're talking about our feet here, getting our feet and our legs moving. Lots of questions about falling. How we got one particular question from a member today. How can I stop falling? So I think this is a two-part question. Why do people in Parkinson's, why do they have more predisposition for falling? And how can we help ourselves to prevent falls?
I would say, the reason why, or one of the reasons why people with Parkinson's disease tend to fall more often than people without Parkinson's really kind of gets back to some of that rigidity and bradykinesia that Dr. Burns mentioned early on in this hour. Essentially, what's happening is the signals aren't getting from your brain out to the muscles in a fluid and coordinated way. And so that can make it very tough sometimes to pick up your feet as easily or as consistently as you should when you're sort of automatically walking. And then people trip very easily, especially under area rugs. I tell all my patients, please take up all the throw rugs and area rugs in your house. It's wall-to-wall carpeting, ideally, or if you have hardwood, be extra, extra careful because you don't want to fall on hardwood. Bathrooms are another area that I worry a lot about people because it's all tile and hard surfaces and usually kind of slippery in there. And so I think that's part of it. It's the tendency to sort of get your foot caught and then trip on something. And then when you do start to fall, your reflexes aren't fast enough to catch yourself and really break your fall. And I think the number one thing that people can do to help stop falling is see a physical therapist. Like those people, the PTs are really so wonderful for fall prevention and Parkinson's, both in terms of home safety, but also, teaching you, techniques to hopefully fall more safely is how sometimes they word it, so that you don't get hurt or you don't get injured if you do fall.
I think, you know, falls are often difficult to ascribe to certain things because they're very occasional,
Mhm.
especially at first. And often a patient will come into my clinic and say, "Well, I was doing something stupid," and I'll encourage everyone to resist that temptation to either say this was a one-off thing or I was just, I wasn't thinking right. Um, you want to try and be a little bit reflective and analytical about what was happening around the fall or falls. So, for example, is it the case that you're more likely to fall before your first dose of medication in the morning or within a half an hour of your next dose, suggesting potentially that there is some relationship between the dosing of your medications and your balance, which is not always the case, but for a given patient, it may make a difference. Or is some form of dystonia contributing to your balance, toe curling, dystonia of the leg, etc.? Um, is it the case that when you fall, you feel lightheaded or dizzy, suggesting that there may be some form of orthostasis or low blood pressure, drops in blood pressure with changes in position that can be treatable with medications to keep your blood pressure up? Um, so you want to think a little bit about what were the circumstances around the fall or falls? What is the relationship between my Parkinson's symptoms, the medications I'm taking, um, and then have that conversation and go through that sort of reflective or analytical process with your clinician and your physical therapist, because you'll you'll their experience talking to other patients may be valuable. I think there's some evidence to suggest that targeted balance training can produce improvements in balance. And some evidence from New England Journal around Tai Chi and maintenance of balance. So those are all things that I think you want to consider when balance is an issue.
Thank you both. And we recently did a webinar on gait and balance. I'd love to ask Brianna if she could post that webinar, that recording of the webinar in our chat. So for those of you who are having lots of really specific questions about balance and gait, I highly encourage you to tune into that webinar, led by Dr. Mantri, not Mantri, Afshari. I want to shift gears into tremor now. We have lots of questions about tremor from our community today. Can you please explain why tremor happens in Parkinson's disease? Why is it related to Parkinson's?
Tremor is one of the kind of core characteristics of Parkinson's. I will say, not everyone with Parkinson's has a tremor, but many people do. And it is one of the kind of four criteria that we look for on a physical exam. The Dr. Burns kind of went over. There's tremor, there's bradykinesia, or the slowness of movement, there's the rigidity, and then there's these walking changes. So we're looking for all of that when we examine somebody. The reasons for tremor are, just like the reasons for trouble walking can be kind of complex. Some of it is probably dopamine related and sort of related to that same pathway in the brain between the middle part of the brain and some of this higher level function that produces a lot of the Parkinson's symptoms. But some components of tremor are not related to dopamine at all. And I think those can be a little bit more complex sometimes to get a handle on, if you will, for treatments and so on, because they might not respond as clearly or as robustly to medications like carbidopa, levodopa.
I would say there are uh, um, sort of basic rough differentiations of Parkinson's subtypes This is not completely evidence-based, but this is often how clinicians talk about some consistent patterns they see among patients. There are some what we sometimes call tremor predominant Parkinson's disease, where tremor is an early and prominent feature of the symptoms. Other patients who are called akinetic rigid subtype Parkinson's, and it is what it sounds like. Those patients may have little or no tremor at all, but largely their motor symptoms are slowness and stiffness. Um, Both of those types of patients can respond to carbidopa-levodopa, but a subtype of the tremor predominant, even if their slowness and stiffness gets better on the meds, they feel better, the diagnosis is not as in question, the tremor is not effectively captured with the meds. That doesn't mean you don't have Parkinson's or you got something else. That is just a pattern we see, sometimes in as many as a third of patients. In those situations, we may try other medications. One is called trifenadil or Artane, and sometimes we'll consider surgical treatments like deep brain stimulation. So tremor is sort of a um, slippery feature of Parkinson's diagnosis and somewhat more difficult to improve with meds.
What about the role of exercise and the management of tremor? Does exercise support tremor at all?
So I would say you want to differentiate maybe immediate effects around your tremor symptoms and the long-term evidence base for the benefit of exercise generally. The long-term evidence base around exercise generally suggests that exercise slows disease progression in general, and so presumably slows progression of tremor as well as rigidity and bradykinesia and other things. Some patients will say, after exercise, I feel better, like I took my meds. Some patients will say, after exercise, I feel a little run down, or my tremor is better, or my tremor is worse after a given workout. That does not reflect disease progression or worsening in any durable sense. And so I don't want people to be dissuaded from exercise because after lifting heavy weights on a given day, they're like, it feels like my tremor's worse. I'm not lifting weights anymore. Um, so that the distinction I think is important uh, important to make.
All right, let's talk about a subject related to tremor um, that could hopefully be beneficial to many symptoms of Parkinson's and the role of stress. How does stress influence or impact the motor or movement symptoms of Parkinson's? And let's focus first to start on tremor.
Yeah, I think stress, can and often does worsen all symptoms of Parkinson's, motor and non-motor. But really, tremor in particular tends to be one of the most visible features. And so people with Parkinson's sometimes report to me that they feel like their tolerance for stressful things is less than it used to be, because it makes them feel more jittery, more anxious, more nervous, and then that makes their tremor worse. And then sometimes they get worried about their tremor, or people are going to notice my tremor. So then they're focused on the tremor, and then the tremor gets even more worse, and then it becomes a vicious cycle. So if that sort of describes you, I think number one, you're not alone in that. It's a pattern that I hear a lot from patients. And it's also a pattern that I think can be really, really amenable to stress reduction techniques in the moment, things like mindfulness or box breathing or some of these other things that you can do if you start noticing that, say, your tremor is very responsive to stress. And I guess the other thing I'll say before turning over to Dr. Burns is that we often think and talk about negative stress, right? Like stressful bad events, but it's important to remember that even positive events are a stressor. They're destabilizing or changing our system in some way. So if you're excited about, something coming up, that can make your tremor worse, and it doesn't mean that the thing coming up is something bad or something to be avoided, but it is just something to be aware of, that both positive and negative stress can impact Parkinson's symptoms.
Yeah, I think that's true. I've got patients who come down from Georgia, and I think they bring this up just to brag, but they'll say, whenever the Georgia Bulldogs are doing well, and I'm excited that they're doing well, my tremor's worse. What's up with that, doc? And so in those situations, any sort of overall stimulus that the tremor may be more prominent. That may happen even if your meds are perfectly optimized. In all other contexts, you feel like your symptoms are well managed and the med is effective. That breakthrough tremor doesn't represent disease progression or something that you necessarily need to do something about. Um, but will happen either even under the most optimized circumstances. Um, it is also the case that sometimes some non-motor symptoms will exacerbate tremor. So a low dopamine state, or Parkinson's disease in general, can cause anxiety, significant anxiety, that sometimes is responsive to carbidopa-levodopa or improved by carbidopa-levodopa, but sometimes requires other anti-anxiolytic, anti-anxiety meds. And the treatment of the anxiety can improve the tremor, as you might imagine. And so I have a couple patients where I don't give them any carbidopa levodopa because they just don't want the med, but we treat their anxiety, and that improves their quality of life and improves their tremor. Finally, significant occasional stress can worsen tremor and other symptoms. So, for example, you're admitted to the hospital for sepsis or a knee replacement, or you're in a car accident, some major serious stressor, or you lose your house, or there a death in the family. Patients will frequently report that they feel like all their Parkinson's symptoms are significantly worse for that period of stress. Um, and available evidence suggests that those patients do revert to the sort of general progression of their symptoms after that period. So I would say in those situations, talk to your doctor, be patient with those symptoms, and you can consider modifications to your medications, but that is a known thing in PD, and doesn't necessarily mean a durable and rapid decline.
Thanks for speaking to some of the non-motor symptoms that influence our motor symptoms in navigating the disease progression of Parkinson's. Since we brought it up, I just want to announce to everyone that we are focusing one of these sessions solely on anxiety, depression, and apathy, some of the really prominent non-motor symptoms of Parkinson's, and that session will be in February, so stay tuned. One question about tremor, another question of tremor on, say you're someone living with Parkinson's, you have a very predominant tremor in one hand and you're experiencing trouble feeding yourself. Any suggestions on how we can control movement to help myself feed myself?
Great question. There's a few different things that come to mind. There are special types of devices. For instance, the LiftWare device, which is a spoon with a sort of gyroscope built into it. And so it vibrates at the opposite frequency of your tremor as you're holding it. And so it keeps the sort of body of the spoon level, and people are much more easily able to get soup up to their mouth. They also have a fork version of this if you're eating something that requires a fork instead of a spoon. So there are devices like that that can be helpful for eating in Parkinson's disease. That tends to be my sort of go-to for a lot of people. And I also often will recommend people meet with an occupational therapist at least once, if not more, to learn more about these types of devices and sometimes try them out in the OT office before you commit to them and buy them. Because depending on insurance companies, they may or may not, unfortunately, cover some of these household devices. So it's helpful if you can try it out before you buy.
I would say that with the caveat that Parkinson's tremor is quite variable, as is Parkinson's in general. So rule of thumb is that tremor with movement um, tends to dampen Parkinsonian tremor, not always, but most of the time. And so if you're having really significant and impairing tremor with movement, say using utensils, holding a cup of coffee, etc., you at least want to be evaluated by a movement disorder specialist or a neurologist with sufficient experience for the possibility that you may have both Parkinson's and essential tremor or another tremor syndrome. Those different diseases are independent of one another. Parkinson's doesn't put you at increased risk for, say, essential tremor, or vice versa. But just by chance, something we have them in our clinic, people who have both things. And the medication management for essential tremor type tremor is different and can also be effective. Finally, when you have a Parkinsonian tremor that's not responsive to carbidopa levodopa or other Parkinson's meds and really becomes impairing, prevents you from doing activities of daily living, including feeding yourself, etc., that is a scenario in which we start talking more seriously about surgical interventions like deep brain stimulation.
Lots of questions about tremor. I appreciate all the questions that are coming through about this particular movement symptom of Parkinson's. I'd like to shift into pain, the subject of pain and Parkinson's. Is pain considered a movement symptom of Parkinson's?
I would say that classically pain is probably considered a non-motor symptom of Parkinson's. However, pain can make it difficult for people to move for all kinds of reasons, right? You can be guarded in your movement to try and minimize the pain. Pain can sometimes be associated or a result of things like dystonia, where you have that cramping or twisting of a body part. And so if that's the case, that needs to be addressed, I think, directly head on, in addition to whatever else might be causing the pain.
Yeah. If you go to your movement disorder specialist or neurologist and endorse Parkinson's related pain, they will likely ask follow-up questions. It's not because they are skeptical of your experience or your pain. It's because what's causing the pain may affect what treatment they offer. So dystonia is a perfect example. Uh, and so, I think if there's a pattern that's consistent with dystonia, treatments like carbidopa, levodopa, and sometimes Botox injections can be incredibly effective. Um, Parkinson's patients are on average older, and so they have other pain-related stuff that's unrelated to Parkinson's disease, orthopedic problems, for example, rheumatologic diagnoses, and so those need to be ruled out. Um, but there is a well-known and poorly understood pain syndrome that can be a feature of Parkinson's disease and can be a challenge to manage if not responsive to carbidopa levodopa. Um, and I think a multidisciplinary approach makes sense. Physical therapist, occupational therapist, sometimes a pain management physician who's communicating with your movement doc, your neurologist. Um, there are non-opioid pain medications that can help. Sometimes opioid pain medications are necessary. And all of that entire discussion about both cause and multidisciplinary treatment approach is important.
Now, what about like daily muscle pain or severe stiffness in calves or thighs? Could that be related to the Parkinson's?
It certainly could be, but it could also be related to a whole host of other things, whether that's sciatica or back issues, or other kind of orthopedic problems or rheumatologic issues can sometimes affect the thigh muscles. So it's important, I think, to have those follow-up questions with your own doctor to kind of hopefully get to the bottom of what's causing it for you so that the treatment can be the most targeted possible, as opposed to sort of just generic blanket sort of pain control that may or may not address the underlying reason why you're having pain.
If you're talking about pain or discomfort in the thighs and calves specifically, often the follow-up question I'll ask is, does that happen at night? Is it more likely when you lay down? Does it get better when you get up, walk around? And what I'm getting at is, does this seem like restless leg syndrome?
Mm.
Which is a common associated symptom of Parkinson's, not so common as to be a diagnostic criteria, but can be seen, can be responsive to carbidopa, levodopa, but can also be responsive to non-dopaminergic therapies like gabapentin or Lyrica. Um, and so if the pain is it's a sort of discomfort or disquieting feeling in the legs specifically, worse when laying down, better when standing up and moving around, that suggests this syndrome that is potentially treatable.
Right. Thank you both. I'm going to offer us one more question. For those who are here recently diagnosed, how important is it? This is a question from a community member. How important is it to see a movement disorder specialist versus a garden variety neurologist, using their words?
Garden variety neurologist. So, this is a very challenging question to answer, I think, from my perspective. And Dr. Burns, I'm interested to hear yours as well. But like, ideally, I would love it if everybody with Parkinson's disease had access to a movement disorder specialist as part of their care team. I do think that the extra training of a movement disorders fellowship, where you're sort of seeing almost exclusively Parkinson's and related, very closely related conditions, adds value in terms of being like diagnostic nuance and different ways of asking a question or different ways of doing a physical exam that can really, really be beneficial. However, I'm also very, very aware that everybody having a movement specialist is not, I think, at this time, a reasonable ask for everyone in our community, unfortunately, just because of the numbers of people with Parkinson's disease versus the numbers of movement specialists and where movement specialists are often located, usually in academic medical centers or in large cities. And so people who don't live nearby one of those places can have a really tough time accessing movement disorders care. So I would say that I would say that any neurologist, any well-trained, board-certified neurologist is absolutely able to diagnose and to manage the key symptoms of Parkinson's disease. If you're able to get a consultation with a movement specialist, even if it's just a one-off thing or a once a year check-in, that is great. But I would rather have a patient be seen as frequently as they need to be, or on an ongoing, continuous basis with the same person. So you develop that continuity and that relationship. That to me is as important or more important than, the credentials behind that individual's name.
Yeah. Yeah. I mean, I practice in Florida, big spread out state. Patients come to see me from southern Georgia, Louisiana, and Boca, and they're driving long distances to get here. Um, and so I I am happy if they've got a local neurologist, whether they're movement trained or not, and I try and coordinate with that person and set up a sort of a care plan in whatever way that works for the patient, whether they check in with me occasionally, they send me a my chart message, we do a telemedicine visit every once in a while. Um, and so, if you have local access to a neurologist, that's great. If at some point in the first, 3 years of diagnosis, you can go see a movement doc at a center once, I think that's useful. And your local neurologist shouldn't take offense to that, because managing PD in particular, there's just so much variation, so many low likelihood, but things that can happen. And that the value of the additional training is that you end up seeing those things happen because it's a referral center and you see a higher concentration of advanced disease. And so you just in those situations were like, you know what, I've seen that a couple times. This is what worked. Um, and with regard to specialty care, I you should try and seek, even if you can't see a movement disorder specialist immediately, think about the other kinds of care that might be useful. Physical and occupational therapy, speech therapy, for example, maybe social worker, a dietitian. And then finally, even if it's not needed now, try and imagine what kind of additional home support or caregiver support might be necessary. Is it important to connect with a therapist of some kind, even either for you or for your spouse, to just get in the habit of discussing issues as they come up. Um, you want to be in a position where you're proactive about providing the multidisciplinary support that a given patient needs for the benefit of the patient, but also the benefit of the caregiver, so that you can maintain the relationship you want. And so the person's caregiver roles aren't crowding out the core important relationship that matters. I do this in my practice. There are often times in which I see a patient, I don't do much for them, but my physical therapist, my occupational therapist, my genetic counselor, my dietitian, they're doing the lion's share of the work. I'm incredibly grateful. That's how I practice, and I'm a specialist. And so that's how you should think about providing care and structuring care for your loved one, as well.
I hear a garden.
Yeah, right.
It's a
Right.
garden with multiple flowers, and yeah,
Yeah.
I love it.
All
Yep.
kinds of different specialties. And throughout Dr. Burns and Dr. Mantri, you each have referred to other specialists in a different scope of practice related to Parkinson's. That's our physical therapists, our social workers, speech language pathologists, um, uh, mental health therapy, our movement disorder specialists, and also our general neurologists. What we have access to, what feels supportive to us in the care that we need as a person with Parkinson's, but also supportive to the person who is supporting me as someone with Parkinson's. Well, thank you, Dr. Mantri and Dr. Burns, for sharing your wisdom and your knowledge with us today. It's been really fun to kick off the coffee and conversations with both of you. And a big thank you to each of you who joined us for the first of our coffee and conversations. Want to share the lineup of what we have to come in the new year. Our next coffee and conversations will be on February 18th. And we will focus that conversation around the non-motor symptoms of Parkinson's, including anxiety, depression, and apathy. If we didn't get to your question or if new ones come up as you process the information, we're here to help. The Parkinson's Foundation Helpline is a trusted live support service available to care partners and anyone living with Parkinson's. It's staffed by nurses, social workers, and Parkinson's specialists, and it's a great place where you can get answers to both medical and non-medical information. And before we wrap up, we have just one last favor to ask you. Your feedback is essential to shaping the Foundation's programming. That's how this series was born, by your voice and you sharing your need for questions to be answered. So as the webinar concludes, a survey will pop up on your screen. Please take a moment to share your thoughts and let us know what topics you'd like to see in future sessions. Thank you so much for joining us today. We're honored to have shared this time with you and hope you found the information and resources helpful on your journey. Please know that you're not alone. Our community is here to support you every step of the way. Take care and be well.
Thanks, everybody.
Yeah, thank you all.